Thanks very much, Rod, and good morning to everyone. It's really lovely to see you all here so early on a Saturday morning, so congratulations for making it. Just wait for my slides. Thanks. Okay, good. Okay, cool. So I'm going to be here talking a little bit about translating HIV evidence into community language. There's really two focuses of this short presentation, which is about good practice in presenting community-based research findings to the community before and after publication. I'm not focusing too much on that one because Rod really wanted me to focus on the second one more, which is about identifying and revising potentially stigmatizing terms in writing research manuscripts for publication. So let's just get right into it. This is just 2 slides. So I don't think I have to tell anyone here, as Raina has just so clearly outlined, the importance of community involvement in research should be from the very beginning right through to the very end. But what I've sometimes seen that even in some of the most well-designed community projects that involve community members in the development and production of the research, sometimes it stops there, and then the researchers get the data and kind of hoard the data, start writing it up, doing their own analysis, and then and go from there and only publish in academic journals. It's really good practice to involve community before publishing your research results. So actually taking your results back to the community, validating them in a way to check, are you agreeing with the interpretations that we're bringing to these data? To make sure you use the most appropriate terminology. Like I said, you validate the interpretation and you notice things. The community members might notice things that the researchers might not see in the data. Of course, what you do and how you will do it will depend on how the research project has been structured from the beginning. And again, Raina pointed out some of the different styles or levels of community-based research that can happen. Best practice would be to have community intimately involved at all stages, and this can include at the very end when you're interpreting the findings of the research. One thing that we do a lot in our setting in Australia, but also around the region, is we present our preliminary findings to community organisations before we publish. So before we even do any public reports or anything, we take it to these meetings, almost like a focus group discussion to say, are we finding what we think we've found? And I think that's been really, really helpful. Another really good thing to do is invite community organisations and staff members to be co-authors on abstracts for publication. So with almost all of the studies that I run, we would do this. We'd go to some of the key community organisations in our setting and we'd ask at least 1 or 2 people to come onto the papers with us. After publication, it's really important to disseminate research for it to be used in policy and practice. A lot of research just gets put up on an academic journal behind a paywall. It's hardly read by anybody, it's hardly cited by anybody. And so it's really important for research to be seen so that it can be engaged with and used. And dissemination of research should go beyond other researchers and include policymakers, clinicians, community organisations and community members. As I said, journal articles are often not accessible, so it's good to try to share those articles and the content within those articles in a more accessible way for community members and community organisations. So again, another thing that we do quite a lot in our setting is we might finish off a research project, have a public-facing report, and then go to the community organisations that we work with and actually present those findings. That means that they've got a PowerPoint presentation they can use that's really accessible, it's in lay language, and then they can actually take that into their work and use it in their work. The other thing that we do quite a lot in our setting is that researchers can work with community organisations to ensure that their findings are presented in non-expert language. So one of the best ways to do this would be in infographics. So sometimes we come up with really complicated epidemiological data that comes out of a study, for example, the opposites attract study that was run on treatment as prevention. And we went to the community organisations and said, can you turn this into a really easy to read and understand infographic that we can put, all of us can put all over Facebook so that everyone can now understand that treatment does prevent transmission. It's a really effective way of going. Right, I've got about 11 minutes now to talk about stigmatising language, which is really what Rod wanted me to focus on here. So I think we all know by Saturday of this conference what stigma is. So it's the actual or perceived shame or disgrace that sets a person apart from others based on an attribute that the person possesses. And there are obviously different types of stigmas. So you can have internalised stigma, you can have enacted stigma, which is actual experiences of stigma, and then there can be anticipated stigma where you're fearing what stigma might happen. And as we know in the HIV space, there is all 3 of these forms that are circulating around. And anticipated stigma is often one of the things that stop people go forward for testing or for treatment. But we obviously know in this region there is also a lot of enacted stigma as well. Stigma can operate at multiple levels, from the individual right through to the structural. Now, in our area, in HIV-related stigmas, they can be related to HIV itself. So that might be things like fear of infection or contamination, all these horrible words. There can be the behaviours that are associated with HIV and HIV transmission. There can be the membership of key populations, and there can be the behaviours, characteristics and social norms that are associated with those key populations. So you can see that it can get quite complicated. It's not just one form of stigma that's operating, it's all sorts of different forms of stigma. And here, I'm not even mentioning all the other forms of intersectional stigma that might come into it too, that aren't actually about HIV or being part of a key population, such as disability, socioeconomic status, and so on. So I won't go into this in too much detail, but HIV-related stigmas of all those kinds have been shown to have many different negative impacts, including things like reduced ART adherence and viral suppression, reduced health seeking, worsened mental health, decreased quality of life, and delaying or avoiding HIV testing. That's just a few examples. There's so much literature in this area. So what are some of the principles? Rod already mentioned the first one here, which is this idea of person-first or person-centered language. So this is language that emphasises a person over their diagnosis or condition and doesn't define an individual by their diagnosis or condition. The second there is empowering or neutral language. So this is language that states things positively or neutrally, rather than negatively, or ways that imply blame or passivity. I'll go through some examples of this in a minute. The involvement in the affected populations, we've already talked about that. Preferred terminology for pretty much anything should always be informed by those living with or impacted by the condition or who are members of the relevant group. And that's really important to pay attention to because terms can change. So you might have learned a term 10 years ago and it might not be the preferred term anymore. So it's really important to stay engaged to see how the language is actually evolving. The guidelines from the US say this thing, we all know the golden rule, which is treat others how you like to be treated. Then they say, well, it should actually be the platinum rule, which is treat people how they would like to be treated. We might not understand the best ways, or we might not have that lived experience to understand how we might want to be treated. So it's really about trying to find out from those people, how do they want to be treated, and then treat them that way. And then my last one here is precision. So this is about language that is precise and clear rather than general and vague. And I'll show you some examples of what I mean. This is a great resource for anyone who's looking for just really practical guidance on what terms to avoid and what terms to use. Look this up because it's really helpful. So let's go through some of these examples. So person-first language is best for some groups. So Rod already mentioned people living with HIV. This is obviously one of the most common terms that's used now, instead of things like HIV infected or HIV AIDS infected or even HIV positive. Now, my personal opinion would be that in some situations it is still okay to say HIV positive, but it needs to be in the right context. Generally, it's something to try to avoid, but sometimes it's okay. People who inject drugs or people who use drugs has become the common term for that particular key population, instead of injecting drug user, which is what it used to be when I first entered this sector, or drug user. And then there's this idea of risk. So there's been a move away from characterising particular groups as inherently risky. So people at high risk or high incidence population, they're the better terms to use rather than high risk people. You see the difference there? You're sort of saying, in one, it's saying the person is inherently risky. They're high risk in and of themselves, which is not correct. They are people who are at high risk because of maybe the situation they're in or the behaviours that they engage in. It's important to know, though, that person-first language doesn't always work. Some communities prefer identity-first language rather than person-first language. And some examples are gay and bisexual men prioritises identity, whereas men who have sex with men has been criticised in some of the literature because it erases the idea of identity and community. But again, I'll go into this later, sometimes it's okay to use MSM, but sometimes it's better to use GBM, or gay and bisexual men. And then avoiding language that disempowers people or is passive. So obviously the first point there, sex workers instead of prostitutes, that's for a range of reasons. Prostitution obviously has a lot of negative connotations, but sex workers is also more empowering because it's saying that sex work is work. So it's really putting work in the name of the group that we're talking about. It's better to use clients and participants instead of patients and research subjects. And then there's a whole range of terms that need to just be gotten rid of in the whole trans space. So it's better just to say trans men and women rather than all these outdated terms. And I am running out of time. It's important to avoid language that blames people. So hard to reach or difficult to reach is sort of saying that's your problem rather than ours. We should be changing the system to make it easier to access, not blaming you because you're difficult to reach. Again, using empowering terms, and avoiding negative ones. So drug use rather than drug abuse, has multiple sexual partners instead of promiscuous, adherence instead of compliance, and using precise or accurate terms rather than ambiguous ones. So condomless intercourse or sex should be used instead of unprotected sex or unsafe sex. We now know there are safe ways to have condomless sex because of biomedical prevention. So it's really good that we just get rid of this old term, unprotected sex, from our writing. And then sometimes in concepts, so in the whole area of treatment as prevention and U equals U, we should be being precise. We should say no risk or zero risk rather than things like effectively no risk, which is what some people still use. The word HIV elimination implies that people living with HIV need to be somehow disappear for us to end the epidemic, which is obviously not true. So we should be more precise. Elimination of HIV transmission. I'm just going to skip over those ones. To get into. So this is a more complicated one. So explanations for behaviours and outcomes can also be stigmatising. So this isn't really about the terms that are being used, it's about the explanations that are being provided by people. So sometimes the issue is not the choice of word, but it's how the author constructs their argument. And so people can have unconscious biases, but people can also purposely try to be stigmatising in their writing without looking like they are. So some common things to look out for are cherry-picking data to feed a preconceived argument, emphasising some findings over others, mistaking correlation for causation, this is a huge one, ignoring the social context and structural disadvantages and sort of making things about the individual and blame, and focusing on the shortcomings of individuals rather than systems. So let's look at some scenarios, and for each one, this was meant to be like an activity where we could actually chat because I thought it was going to be a smaller room, but we're just going to have to do this more quickly. Identifying the source of concern or the problem and then thinking how it could be done better. So for this one, the study involved 90% gay identified men, 9% bisexual men and 1% heterosexual men, but the research is using MSM to describe this sample. So do we think this is okay? Do we think there's something better we could use? We don't really have time because we can't use the microphone, so I'll just go quickly into it. So in this particular case, it would be better to use gay and bisexual men because you can see there that all of the people involved in this study were actually gay and bisexual identified people. We're not talking here about a sample that involves a lot of men who have sex with men who are not identifying in that way. This is in a more of a Western context. I understand that in other contexts it's different. I totally get that, and I'll get onto that in a minute. This one involves 35% gay men, 20% bisexual men, 30% heterosexual men who have sex with men, and 15% transgender women. But the researcher still uses MSM. So what's wrong here? Clearly, this is a group that's made up of some people that identify with the community and some people who don't, but it also has trans women in the sample. Trans women are not the same as MSM, and this is still a mistake that's being made around the world in many, many papers. This one, the article says 50% of the HIV/AIDS infected patients caught AIDS from injecting drug use. So there's a few ones here. Clearly, we don't use HIV/AIDS infected. We don't use caught AIDS. You can't catch AIDS, you acquire HIV. And again, like as I said before, we don't really use injecting drug abuse. We might say injecting drug use in that case, to be more neutral. So the article says, we conducted qualitative interviews with 23 women who choose to engage in prostitution and were addicted to drugs. These are all real examples. I'm not saying where they come from, but these are all real examples. So in this case, again, we prefer not to use the word prostitution. Addicted to drugs is not good. You might say use drugs. And pointing out there the chose. That's really responsibilizing and individualizing and blaming. This one was a study was a cross-sectional survey and found that many socio-demographic and behavioural characteristics were associated with condomless sex. And then in the discussion section of the article, the researchers say, it was clear that alcohol use caused unsafe sex in our data, and then write a big long paragraph focused almost the entire discussion on alcohol use. Now this is this more complicated one about the stigmatising explanations. So what's going on there? Well, they found a lot of things that were associated with condomless sex, but they chose to just focus on the one, which was alcohol use. And they're kind of blaming alcohol use. Can you notice the other problem here? They're using the word caused. In a cross-sectional survey, you can't say anything about causality, you can only say something about correlation. There's associations in the data, that doesn't mean that alcohol use caused anything. And the last one here, the article says the AIDS-infected population is difficult to find and do not come to the hospital to access treatment even though it is freely available. So you can see here with this one, the researchers or the people working in the hospital are saying, why can't they just come to us? It's just easy. But clearly it's not. If you're using terms like AIDS infected, which is a completely outdated and inappropriate term, then maybe there's a reason why people aren't coming to your hospital. Now I've run out of time, but I will just go through some caveats. As I said before, language is always evolving, so it can take time for a new term to become broadly used. There's going to be people with different levels of knowledge and understanding, so a bit of grace and gentle correction can go a long way with this stuff. Rather than sort of fighting someone and being angry at someone, just gently correcting them, and hopefully they learn the lesson. Changes to what is preferred and what is viewed as offensive can happen really quickly. One area where a lot is happening very, very quickly at the moment is in the trans space. So we've really got to focus there on what are the most appropriate words to use, particularly in that space. There can also be disagreement within a community about what the most appropriate terms are. There are some people who really do not like the word queer in the gay and bisexual community. They hate it, they think it's offensive, and others absolutely love it. So we as researchers have sort of got to figure out what to do about that. I'm way over time. All right, let's go. So sometimes there are just some constraints. There's word limit constraints. There are some other things that make it difficult for people to use words in the right way. Obviously, preferred terminology is language specific. So I've been talking about English language here today. Most published research in academia is in English, but some concepts and terms in English don't translate well into other languages or vice versa. Some concepts can be translated into other languages, but the translated term won't actually make any sense to anybody in the target language. So some decisions sometimes have to be made about balancing comprehension versus using the most preferred term. And it's also just important, last point, to note that people who speak English as a second language may not always be completely up to speed on the most appropriate words to use within the English language. And so again here I just say native English speakers should be aware of their privilege, and a bit of gentle correction and a bit of grace can go a long way here rather than getting angry. So I'll leave it there. Thanks very much for the opportunity to speak.